Good afternoon or good morning, depending upon which part of the country you're in. This is Ron Bialik with the Public Health Foundation, and I welcome you to today's webinar, Taking Action on Community Health Improvement Priorities. For those of you who are not aware of the Public Health Foundation or familiar with us, our mission is to improve public health and population health practice to support healthier communities. And we do this through developing tools and other resources, as well as providing technical assistance and training both on-site and in the field. Our webinar today is part of that distance training that we'll be providing to you. And let me turn this over to Kathleen for a moment for housekeeping items.
Absolutely. Thank you, Ron. So before we get started, we just wanted to run through a few housekeeping items. So on the slide that you have in front of you, you should see a control panel, which should look the same as what you have on the right-hand side of your screen. So first, we wanted to let you know that all attendees who've come into the webinar today are muted, so you're in listen-only mode. If you are using your phone to listen to the webinar, please choose the phone call option and enter your audio PIN found in the audio portion of that control panel. If you're using your computer speakers and mics, please choose the computer speakers option. And that should help cut down on any echoing or background noise for you as you're listening to the webinar. We do, as you can tell, have slides for the webinar. We have uploaded a copy of the slides into the handout section that you should find in that control panel. So if you want to download or save a copy of those, you can follow along. I'll also note that there are a number of links embedded within the slides. They're not live on the webinar platform itself, but if you go to that handout, download that copy, the links should all be live and you should be able to click and go from there. We've also uploaded into the handout section a copy of a poster that Brett, one of our presenters today, presented at a conference earlier this year and wanted to share with you all. Please, we'd love to hear your questions throughout the webinar. Please feel free to type your questions in the questions box or your comments for any of our presenters, and we'll have some time for Q&A at the end of the webinar. And finally, we just wanted to let you know that the webinar is being recorded and will be archived, and the archive will be made available following the webinar. Thank you. I'll turn it back to you, Ron.
Thank you so much. Well, during today's webinar, we're going to be talking about the initiative using the Community Guide for Community Health Improvement Pilot Project. And this initiative uses the Guide to Community Preventive Services, and we'll be talking about that in a moment, and a population health driver diagram framework in the field. The bigger part of this discussion, however, will be from the two hospitals involved in the initiative this year, and they'll be talking about the actions they're taking, and of course we'll provide an opportunity for you for some questions and for us to provide answers. Before we move on, I want to thank the Association for Community Health Improvement and the Catholic Health Association for their partnership throughout this initiative in identifying hospitals to participate, providing tools, conducting communication, etc. And also I want to thank the Centers for Disease Control and Prevention for having the insight to engage hospitals and public health agencies in this type of initiative, and also, of course, for providing the financial support for this as well. Today's presenters are Jack Moran, and Jack is with us here at the Public Health Foundation. He's going to talk about the driver diagram framework and how that was used. Brett Sierra is going to talk about the use of that by the hospitals and how they've been taking action within Secours, Hampton Roads. Coletta Barrett and Monique Marino from Our Lady of the Lake will also be talking about the actions that they've been taking as part of this initiative. And then to wrap us up, we have Shauna Mercer from the Centers for Disease Control and Prevention, who'll be talking about a little bit more about the community guide, as well as future directions and actions being taken with the community guide. So I want to talk for a moment about the pilot initiative itself. We're in our, I'm sorry, before we move on to that, I wanted to conduct a poll. We really would like to know who it is participating today. So, Kiona, if you could put the poll up there. Okay. Kiona, how are we doing with responses?
We have about 70% of the attendees respond.
Okay, well, maybe we can close the poll and see who's here with us today. So now we should be seeing it. So we have a good mix of hospitals and health systems, as well as public health agencies, and then also some nonprofit organizations and others. For those of you who are in the other category, if you don't mind, over the next couple of minutes, you could just type in the type of organization you're with. That way we'll be able to have a better idea of who is joining us today. So thank you so much for participating.
And Ron, excuse me, do we want to tell them where to type it in just so that they know?
Oh, certainly. Thank you very much, Shauna. Please type in that information in the questions part of your screen. So you see on the right-hand side in your, is it called the control panel? Mm-hmm. That's where you can type in the type of organization. Thank you, Shauna, for that reminder. So the pilot initiative itself has involved 4 hospitals. Last year was WellSpan and Integris, and this year we're delighted with Secours and Our Lady of the Lake are involved in this initiative. And what this is all about is the various hospitals engaging their communities in priority health issues that have been identified through the Community Health Needs Assessment and or the Community Health Improvement Plan. What they've done is identify that activity, engage public health and other stakeholders, where we've used the driver diagram then to work on aligning efforts and helping the communities take some action around those areas. One of the key resources for this activity has been the Community Guide. And again, Shauna will be talking a little bit further about the Community Guide a little bit later on. The Community Guide contains evidence-based findings and recommendations. And what's important about that is there is this group that goes through a systematic review of literature and pulls out key findings and key information that then communities can use for evidence-based strategies. In addition to the Community Guide as a key resource, we've also had the framework, the driver diagram framework, as a key resource for the communities throughout this initiative. And Jack Moran is going to talk with us a little bit about the driver diagram framework and how it's been used. Jack?
Yes, well, anyway, we've done in both of these 2 hospitals, as you will see, is they took the role of being the anchor organization to get things started. And by starting it, they began to introduce it to other parts of the organization. They developed a draft diagram and then rolled it out to other partners in the community who became part of the teams that went forward to solve some of the problems. And again, if they all recognize, as we do, is that we're not going to be able to do this alone. We have to have cooperation between the hospitals, the healthcare organization, and public health, as well as the other traditional partners in the community, whether it's faith-based and those types of things that can help us pull people together to move it forward. We want to reduce the silo effect with many people doing small pieces and get many people doing a really big piece that can move forward. So next slide. And again, when we look at a population health driver diagram, it represents the team members' thinking. Originally, what we do is we get a small group together to develop the draft diagram, and they think through what's the cause and effect in the system, and think about how this is going to come together in projects and so forth. And then what they do is we get together with a larger group. Sometimes it's as many as 100 people from the community, and we have a process where we go through, and everybody gets to see the driver diagram in its totality, make comments, and then we update it and have a final driver diagram that we move forward with. And again, we want to, throughout this, begin to look at where can we measure and monitor to make sure the changes, if they've been made, are effective. And again, we want to make sure that we continue to look back at what we developed and make sure that the theories we thought about are actually working in this case. Hit the next slide. And what you see in this case is this is what a driver diagram looks like. The first thing we do is we define a name for the process. High level, 50,000 feet. Then we develop goals for the process, and hopefully we have many that are measurable and can have a baseline to start with. Then we start to develop the primary drivers. What are those things that are going to push us forward? Large buckets. And then down to the secondary drivers, which begin to look at more projects in this case. And on the next slide, what you'll see is as we begin to do it, the aims, the goals, primary drivers, secondary drivers, now we want to think about what are the leverage points. The first group, aims and goals, define the change. But the leverage points now become what the driver, primary drivers, secondary drivers. And then we start to look at what are the community change concepts that we come up with. And in the community change concepts, this is where people bring in their ideas, their hunches, their evidence, their opinions, and the teams work through it and start to develop some potential trial solutions that they can go out and work on. And as you see in the bottom, this is where we get down to the specifics. And we talk about, if you're familiar with it, the plan, do, check, act cycle. So as we're going through this, we're constantly looking at these PDCA cycles to really refine what we're doing, and then have metrics in this case where we have baseline, and then we can develop what the improvements have done. And then finally, when we get to the end, we have a change package, something that worked and that we can really implement throughout the community. In some cases, you might try something in a clinic, one clinic, pilot it for maybe 2 or 3 months, see how it works. And then if it works, we can make a change package out of it. If it doesn't, we can adjust it, try it in another clinic, or maybe something that one of the community partners might test in their organization. I was always going through this PDCA cycle where we're doing planning, we're doing it, we're checking it, and then acting on the system as we're going forward. Now, can I have the next slide? And this slide, this is one that shows you what one looks like filled out. And, here's enhancing physical activity opportunity for all. And as you see in this case, we have the aim statement, reduce disparities in access to physical activity opportunities. Here's some goals. Here's some primary drivers. We usually have anywhere from 3 to 4. And then you start to see underneath those, the secondary drivers. And again, as we begin to look at the secondary drivers in the process, what you're able to see in this case is there are some specific actions that can be taken. And then if you remember back to the last slide, that's where we would start now to get down into teams, which would look at some projects. And projects in this case go forward, community change concepts. Maybe there's something already in existence that's being done, and we can enhance it. Maybe there's nothing in place, and we have to start something new. But the whole idea will be to just, get back, get the metrics, and then begin doing the projects. And I always show this slide. If it was easy, it would be done by now. It looks very simple when you look back at that last slide on the physical activities, because what it looks at when it's all filled out, that's many hours, many days of work with many community partners to get something that gives us a very solid filled-in driver diagram to move forward with. So you will now hear from Brett and at the Secours Maryview Medical Center. Brett was very involved with developing this, and you see his poster that he has came out very well. So I'll turn it over to you, Brett.
Thank you, Jack, and I want to thank all of our audience members today for allowing me to share our experience using the driver diagram process. The next slide, please. Just a little background about Bon Secours Maryview Medical Center. It's our only public hospital in the city of Portsmouth, and the population of Portsmouth is of roughly 95,000 people. Portsmouth is also home to a naval hospital, but a lot of the work that we're doing impacts the larger part of the community, including those military members. To get the project off the ground, Bon Secours worked closely with Healthy Portsmouth, a citywide health and wellness initiative committed to changing policies, systems, and environments to improve the health of Portsmouth citizens. And members of Healthy Portsmouth include the Portsmouth Health Department, American Heart Association, American Diabetes Association, local schools, and other community stakeholders that really feel passionate about impacting the health and wellness of Portsmouth residents. And based on the health disparities present in Portsmouth and the local efforts that were already underway through our partner organizations, obesity became the focus of the population health driver diagram process. We had a lot of statistics to back this up, including our community health needs assessment information, local data that was available through the Portsmouth Health Department, and just the climate around obesity now. through public health. Next slide, please. So this is our Portsmouth Virginia OBC driver diagram. Jack Moran was a very huge help in getting this off the ground for us. We started the process back in January of 2017, and over 4 meetings throughout that year, this is the product. 4 of our main primary driver focuses were collaborating to make the healthy choice the easy choice, promoting active lifestyles, promoting healthy eating, and establishing prevention communication. Now, a lot of this work was already happening in silos, so we're happy to have an opportunity to use the driver diagram to do some asset mapping and figure out who's doing what and how can we work collaboratively to get the message across a broader audience. Next slide, please. So our impact to date. We've been able to address many of the secondary drivers through collaboration and mapping what work was already being done through Portsmouth. Like I said, we had a lot of work going on already, but just getting it all synchronized was a huge process, and the result has been fantastic thus far. The process has provided healthy Portsmouth partners with more opportunities to collaborate on joint projects to address the health disparities experienced in Portsmouth. And some of our successes to date are improving access to healthy nutrition through mobile markets. And a huge asset of that was also having local farmers to take part in these mobile markets that accept SNAP benefits. So that's huge for our underserved community. And we also have some great partnership that's diving deeper into some specific neighborhoods in Portsmouth to make a larger community impact. Some of our future plans for the driver diagram and our partnership as a whole is to expand our collaborations to enhance early intervention strategies for obesity. One organization that we're really working with to improve this and enhance this are the local school systems, and providing some sort of intervention strategy for students and getting them involved in their health at an earlier age than we often see. Next slide. All right, that's all I have right now. Thank you.
Great. Well, thank you.
I'm sorry, I'm going to turn it over to Coletta and Monique.
Thank you, Brett.
Thanks, Brett. If you'll advance the next slide. We're from Our Lady of the Lake Regional Medical Center in Baton Rouge, Louisiana. We're part of the Franciscan Missionaries of Our Lady Health System. We are the flagship academic medical center and have a pretty large footprint in the community that we serve. On this slide here, I'd like to note specifically the LSU Health Baton Rouge. This is a safety net clinic support system that we acquired in the public-private partnership with the state when the state public health hospital was closed in our community in 2013. And as a part of taking on the academic teaching of the residents and GME, we assumed management of the safety net clinics. That's important for this conversation because located within LSU Health is the Early Intervention Clinic, or the EIC clinic as we refer to, which provides singular focus and clarity around HIV care. What's important to know about our mission, being that healing and spiritual presence for each other in the communities that we are privileged to serve, is that we began this journey around looking at HIV as a part of the community health needs assessments. Our Lady of the Lake is a part of the Mayor's Healthy City Initiative. Much of what you heard about Healthy Portsmouth, you also hear about Healthy BR. In 2010, that not-for-profit was created by the then mayor of Baton Rouge and became the backbone organization for the collective impact model for doing a collaborative community health needs assessment in 2012. And in 2015, that organization facilitated the development of a joint community health needs assessment and a joint implementation plan. Both of those assessments and implementation plans had a focus around HIV care. So we were on this journey to address HIV care, and you might want to ask, is it really that significant a problem? Because in our communities, really not. Next slide, please. This gives you a sense of what a significant problem this is. This is a snapshot out of our community health implementation plan that's publicly reported on the Healthy BR website. And so this is the data that we have face up out to the community that gets reported on and updated annually. I'd like to note for you that you see some gaps in these measures for 17, because these truly are measures that take a while to gather from not only our State Department of Public Health, who is our partner in this, but also with CDC, etc. So it's very, very important where this is concerned that the secondary drivers that you're going to see in our roadmap, our driver diagram, are really very important, because they are the guides for how we continue to know about what we're doing makes a difference. We did not have a focus around sexually transmitted infections. We kept our focus on HIV, and specifically focused on opt-out testing for emergency rooms to increase access to care. That's where the lake had its focus, but with the Mayor's Healthy City Initiative, it had a multi-stakeholder collaborative that had been working on how to address HIV. But with the being blessed to be chosen to be a part of the Public Health Foundation and Catholic Health Association driver diagram work, it then began to help us move in a different direction about how all of our stakeholders work together. Monique, next slide.
Okay. So we, just like Brett, we worked with Jack. He came in and met with, he started with us as the host for this project. That was back in the fall of 2016. And we gathered very quickly. We ramped up and we went straight to our mayor's office for their blessing to work on the identified, priority of HIV/AIDS. We also went to our Office of Public Health and made sure that we had their buy-in, that they didn't feel like that we were stepping on their toes, but instead we were just going to help continue their work and kind of align, all the parties. And there are a lot of parties in the Baton Rouge area working on HIV/AIDS. So we invited them to the table. In fact, the state actually shared their list of stakeholders and we invited them to the meetings. Some of our lessons learned, I'll just kind of get ahead, they didn't all come to the table, and we didn't necessarily as a hospital have the leverage to get them to the table. So that's something that, lessons learned, we're doing a little different a year later now as we've transitioned. But I'm getting ahead of myself. With Jack's help, and with everyone gathered in the room for the first meeting in January of 2017, what we brought to that group of stakeholders was every objective or goal that we already had on our community health needs assessment. So we didn't recreate the wheel. We took all the work from the previous 3 to 6 years and said, let's put it on paper on this health driver diagram as the goals. So you can see that on this slide, some of the big goals that really stood out that people were very excited to work on or to continue to work on were increasing the number of individuals tested, making HIV screening a routine, just a routine thing done in all healthcare settings, decreasing community stigma. That was huge. There was a really active work group around that, and keeping patients in treatment or in care and being able to live with their disease. So then what happened is we gathered, we broke ourselves down into 4 committees. Those are the primary drivers. And you'll note, and it's not surprising, that testing in all healthcare care settings was heavily staffed by committee members that are professionals that work at the federally qualified health centers or in our private clinics or in our public-private partnerships. our Knowledge and Education Committee was staffed by a lot of people in the public sector, Department of Health and Office of Public Health. We wished we had had more universities and representation from our local public school system. So again, something we're working towards now. Policy and communications, that was a difficult one to staff because a lot of the stakeholders around the table are the, frontline folks. They're not maybe the higher level leaders of their organization that even speak the talk of someone in policy or government. So that one was a little bit difficult to staff. So we muddled our way through that. Access and coordination of care, again, lots of clinic and state office representation on that committee. Those committees actually developed our secondary driver. So they owned it. They created very large lists of bullets in the original meetings, and then they dwindled it down as we worked through the process of using this diagram. They dwindled it down to the few bullets you see on each side. Now, what's really cool is if you go almost like 8-9 months later, you go to the next slide, and you'll see where we kind of landed or some of our accomplishments. So you see the testing in all healthcare centers. What we did with that is we said, okay, we're going to make sure that makes it into our 2018 CHNA. And since then, since these talks, since the use of this work group and this diagram, we've actually gotten 2 other large hospitals in our area to agree to do the opt-out testing in their emergency rooms. It hasn't gone live yet, but we have their commitment, and that's huge because that's been in the years of making. But I guess, again, bringing people together and doing it where you had the support of your peers, but you also have the support of your local government and your state government. Knowledge and education, we really, we made a lot of headway on this one. We actually hosted a HIV/AIDS Summit, which you'll see in one of the secondary driver sections. I think that's under Knowledge and Education. We actually hosted that summit in January of 2018. And during that summit, we signed the Fast Track Cities Agreement. And then from that was born, if you kind of go back up to Knowledge and Education, that we are going to, by signing that agreement, we agreed we will use the 90-90-90-0 from that agreement. And if you go flip to the next slide for me, we'll show you what we're talking about when we say 90. 90% of the people with HIV, knowing their HIV status, 90% are on a antiviral therapy, 90% are achieving viral suppression, and 0 discrimination and stigma against people living with HIV. You can go back to the next slide, which is a repeat of the previous slide we were on. Going back to our accomplishments, we also made huge headway in the retention of care. So this is that coordination of care. We are lucky enough that we I guess garnished the attention of a national pharmaceutical company who agreed to come in and pilot with our community and our Mayor's Healthy City initiative on a retention of care project. That pharmacy is ViiV, and they're going to actually work with our community clinics to make sure that we do best practices and the latest and greatest to keep people in care. So that's super exciting. So that's kind of like a little summary of our accomplishments of the work using this population health driver diagram and the community guide. I'll punt back to Colette for some more lessons learned.
Yeah, so to kind of wrap up about what we've learned, it was really very important for us to know that with Healthy BR, or the Mayor's Healthy Cities Initiative, that we would be able to maintain and retain this focus and effort with the change in administration. With the election of a new mayor in December of 16 and taking office in January of 17, many eyes were on the fact of, would this work continue? What we counted on, and it came to fruition, was making sure that this population health diagram work continued and people began to see where their place was in this. As Jack talked about, it helps you prevent getting into a silo mentality. And so bringing all of the stakeholders to the table and making sure that we were deliberate, following through. We had a product that we could share at the end of this journey that other people looked at and saw where they could enter into and impact was really very, very important. So our lessons learned moving forward is that we believe that this approach and this process has merit and is achievable. And so we have recommended that the other 3 focus groups in the 2018 Community Health Needs Assessment around access to care, mental and behavioral health, and healthy living use this approach for their backbone for the implementation plan that we're in the process of developing now. Now that the board has signed off on the 2018 Community Health Needs Assessment, we roll up our sleeves and we begin developing the implementation plan. And it is our intention to use this population health driver diagram approach to develop the other 3 key priorities for our Community Health Needs Assessment. So that's it for Baton Rouge, and we'll turn this over now to Shauna to take us on a deeper dive through the community guide.
All right, thank you so much, Colette and Monique, and appreciate very much the Public Health Foundation for putting this webinar together and hearing the stories of the hospitals that have presented to date, as well as, of course, Jack talking about the driver diagram. So why are we talking about the community guide at this time? Both of our hospitals previously have documented what they had as challenges in trying to go through community health needs assessments and then addressing the issues, the needs that were identified, coming up with implementation strategies. Well, one source of information about implementation strategies in the community realm comes from the community guide. And there are 2 things that you're going to hear me talk about, the community guide and the Community Preventive Services Task Force. Let me start first with the Community Preventive Services Task Force, or Task Force for short. What is this task force? Well, it's a congressionally mandated task force that's mandate is to improve the health and safety of communities in the United States by identifying proven interventions that they can implement. And so what is the community guide then? Well, the community guide itself is a collection of all of the task force recommendations and the evidence on which they are based. And this information together can provide decision makers in communities across the USA with evidence-based options that they can look at and select to address their particular needs. Next slide, please. So where does all of this fit? There are many different models of community health improvement planning and going from community health needs assessments to implementation strategies. This basically identifies the specific steps. The first thing one does is identify what's the problem. The second is trying to figure out what they want to achieve. And so once they determine a need, perhaps through this community health needs assessment, they might look at Healthy People 2020 or other objectives that are set by communities to figure out what they need to address. Well, then when they're trying to figure out what works to help address that problem and achieve an objective, figuring out what interventions are out there, this is where the community guide fits. The community guide identifies interventions that work to achieve various objectives. The community guide also helps with implementing interventions. The community guide staff here provide technical assistance to people in trying to figure out whether something might fit their community and how they would do that. And of course, a final step in that model would be evaluation. Next slide. So let's do a slightly deeper dive now into what the community guide is itself. As I've said, the community guide is a collection of the task force's evidence-based recommendations and findings. And what these recommendations do is identify effective programs, services, and policies that can be used at the population level or within communities. And the aim is to identify a number of options that decision makers can look at to figure out which ones might meet their specific needs, since every community is different. Next slide. Again, the second component of the community guide is the evidence that underlies those recommendations by the task force. And this evidence is in the form of systematic reviews that analyze all of the evidence that exists on the effectiveness of particular interventions in public health. In addition to looking at whether an intervention works, yes or no, the information also is whether it works in different communities, whether it works when implemented by different individuals, and many other things that are important to how an intervention works in different communities. One of the most important is the economics of those interventions. Every time the task force identifies an intervention as effective, it looks at cost effectiveness, and cost benefit, because in many public health areas, cost is the most important consideration. And the final thing that the systematic reviews do is identify where there are evidence gaps in the evidence. And here we've identified the website for anyone who wants later to go. They can just click on the site there and go directly to the communityguide.org. Next slide, please. So who are the people that we intend to have use the community guide? Well, if we think about the use or who is looking for interventions that work in the public health frame or within communities to try to improve health and well-being, the first group is state, tribal, local, territorial health departments who are required to address these issues. And then the second is other large organizations and agencies who are accountable for the health of their populations, their communities, or who otherwise benefit from their populations being healthy. And in that area is federal programs that are required to provide services or support communities. The second broad area is hospitals and healthcare systems, like many of you on the phone today. And the last would be large employers who are responsible for the health of their populations. Next slide, please. So to assist all of these audiences, the task force makes recommendations in a wide number of areas. There are currently about 230 recommendations and findings that are compiled in the community guide, and these cover the 21 priority topic areas that are included here. So now let's go through and see what this would look like in terms of the kinds of interventions. And I am going to just highlight as an example here the fourth one down on the left-hand column, cancer. Let's say you had challenges in your community with not enough people coming in for colorectal cancer screening, as an example, and this was affecting rates in your community. So here we have on this slide, thank you for changing, the community guide looks at 4 different types of community preventive services. The first is informational and educational interventions. The second is behavioral and social sciences based. The third is environmental and policy interventions. And the fourth is health system. So for the first, informational and educational, one of the things the task force has done is say, what is the effectiveness of handing out pamphlets? Does that actually help reduce colorectal cancer screening? And then there are things like group education, one-on-one education. Do these things actually bring more people to have screening? If you look at environmental and policy interventions, well, is it effective to try to provide transportation assistance, translation assistance, change hours of service? Do these things actually get more people screened? And if you look at health system interventions, what is the effectiveness of provider assessment and feedback interventions? Can these things increase colorectal cancer screening in a community? Now, for behavioral and social sciences-based interventions, there wasn't a specific one in the colorectal cancer screening area that was important, that was an effective intervention to show you here. And so I've identified one that's another really important issue for many people, and that's addressing diabetes. So our combined diet and physical activity promotion program is effective in preventing type 2 diabetes among people at increased risk. So these are the kinds of the breadth, the scope of things that the task force looks at across all of those priority topics. And just before I turn the slides over now, I just wanted to highlight that as we've looked at these different kinds of preventive services and the fact that the task force does provide evidence-based strategies for people in each of these areas, we were interested in how many of the hospitals are actually using evidence-based strategies from the community guide or from other sources. And so we did some analyses in 2013 and 2016 looking at hospitals and what they had put forward in their community health needs assessments and their associated implementation strategies, and found that they identified approximately 300 and a little more than 300 implementation strategies across this sample of 100 in each of those years. And of those, only approximately 3% of the strategies that were implemented, between 3 and 4%, actually were community-wide evidence-based strategies. So there's a lot of opportunity to identify to hospitals and others the evidence-based strategies that exist and that are options for people. And so what we're going to do now is turn to Ron Bielik, who is going to take you through a couple of questions that might help us in the community guide understand how we might better meet your needs in identifying what are your most important drivers and how we can make sure that we are making information available to you all as you try to figure out how to address needs in your community, whether from a health department or from a hospital. Ron?
Thank you so much, Shauna. And we have 3 polling questions where, again, your feedback here is really important to all of us so that we can do the best job that we can, CDC, Public Health Foundation, other national organizations, so that we can all be helping you in your efforts to develop and select population health initiatives to address priorities within your communities. So the first question relates to your organization and whether or not you've implemented new or enhanced community services or interventions in the last 3 years. So the poll is now open, and please respond. Okay, so far we have about half of you who've responded. A couple more. Great, so Kiana, let's close the poll. And what we see is most of you on the line have implemented new or enhanced community services, and some are in the unknown area, which may have to do with the way we ask the question. But it's really good to know that there's activity out there around implementing and enhancing these interventions, because that, I think, Shauna, demonstrates the importance of the type of work that CDC is doing in this area. The second poll, we'd like to know the primary driver behind the selection of new or enhanced services or interventions. So this will help us know where it is you look for this type of information, or what it is that's driving, the type of information. So the choices are the IRS requirements. Is that driving your selection of interventions and services? The medical hospital readmission penalties, public health accreditation or other types of accreditation for public health, grant requirements or others. And if you select other, as you did before, please, in the question area of the, what's it called? The
control panel.
The control panel, that question area, please write in what your other is. So I think we're opening up the poll.
We have about 50% so far.
Okay, we're at about 60%. Okay, how about if we move on from the poll, and the results here are, so we definitely see that the IRS requirements are a driver and public health accreditation are a driver. So it seems like 2 big and grant requirements, that requirements are a big driver. And I think we have a variety of others in here. I don't know, Kathleen, if you can read off any of those.
Yeah, in terms of some of the other answers, someone just wrote it's the right thing to do. We need to be moving upstream. CMS contracts. One group made a selection based on knowledge of a model that was successful in Canada to meet a need that they found in their own community. Changes to screening guidelines and community education. So a variety of things like that. Share data from competitors' hospitals. Our hospitals and public health led the way to new or enhanced implementation strategies, community needs, community, clinical, and individual care. Yeah.
Great.
So there's a variety of answers there. Thank you so much for that.
Great. And let's turn to our final poll. What we'd like to know here is, where do you turn for the information that helps you with identifying and selecting the community services or interventions? And so we have, previous successes, previous experiences that you've had as one item, peer-reviewed literature, what you might see in journals and other literature, the community guide itself that Sean has talked about, the U.S. Preventive Services Task Force, and its recommendations and other sources of evidence. And again, if you put in other, if you would be so kind as to type in some of those others, that again will be helpful to all of us to know where it is you turn for evidence. So we have about half of you responding at this point. Keep it open for another minute or two, another moment, not minute. Okay, Kiona, how about if we close the poll? So clearly, previous experience and successes plays a big role, and the data that you collect. Use of the literature. The community guide was high up there as well, and and I don't know, Kathleen, if you have any of the others that you can read at this point.
Yeah, again, so feel free, as Ron mentioned, feel free to type, if you have other answers, feel free to type them in the questions box, and that will be super helpful. People have commented on a variety of sources, including, as mentioned on the slide, SAMHSA, CMS, CDC, other evidence-based programming, NAC, the National Association for Community Health Centers, if I've got that right, Healthy People 2020, so things like that, and patient needs assessments.
Great, great. Thank you so much again for participating in the polls. So now what we'd like to do is to open this up to your questions. We have several that have come in. As a reminder, you can type in questions in the control panel. Is the questions area where you can type it in. And if we don't get to your question while we're online, we intend to follow up this webinar with sending people to the archive, and we'll also be sending responses to questions that we're unable to get through during the live webinar. So Kathleen, have we received any questions thus far?
Absolutely. So I think, Jack, you might be in the best position to answer this first set of questions, which relate to the driver diagram. Specifically, at what stage do you recommend to complete a driver diagram for a community health improvement planning process?
I don't understand what stage.
Probably how far along in the process would the driver diagram come in and be really helpful if you're doing community health improvement planning? Sorry about that.
Right at the beginning.
Right. I think what we've found is it really helps to organize the discussion and solidify some of the alignment and the willingness of organizations to work with one another.
And building off of that, so a follow-up, who do you recommend puts together the driver diagram? Would it be the CHIP planning committee or health priority action teams or some other group? Do you have recommendations of who should be involved in that process?
It would be the ones that are most closely related to the project that's going forward. I think it's very hard to say which group, because what we found is in different hospitals, different groups have different names and they're somewhat similar. It depends on who's really going to spearhead it going forward. And that's the key part of it, who's going to own it as they move forward and who's going to be able to staff it and make sure for the first part that they get it done in a reasonable period of time.
And then often there's a very small group to start with that has sort of the trial balloon driver diagram that then the community organizations, when they come together, have something to discuss and something to react to. Kathleen?
Great, thank you both. Coletta, Monique, our next question is for you. And the question is, I'm curious if any of your secondary drivers were already being worked on when you began ramping up, or if these were targeted efforts to support your primary drivers and were new work initiatives. Could you tell us a little bit more about that?
Yeah, it's probably a combination. In other words, like we were already doing opt-out testing in the Lakes ED, but as you saw from evidence-based practice, research said we needed to expand that. So putting it on here to say all healthcare settings was an important expansion. I'd say, you know, all of the discussions around knowledge and education, making sure that we had done an HIV summit, but it was mostly around stigma. And not necessarily around policy and or sustainable measures to address HIV. So that was important, and that was a part of the secondary driver. Most of the policy and education communication efforts, I want to say came out of the driver diagram as new approaches when you talk about targeting the populations and where they get their information, and then looking at who accesses that and who is the best partner to drive that information. So that was totally driven from the secondary drivers. And then, of course, we were doing linkage to care and navigation as a part of our overall, but then it validated what we were going to be doing differently going forward.
Great, thank you, Coletta. Another question, either for you all at Our Lady of the Lake or Brett, I'm sure you can chime in on this as well, relates to program evaluation and how you're incorporating program evaluation into your projects or into your work. Do either of you have any thoughts on that?
Yeah, I'll chime in. I think program evaluation is very important for this work. And that's something that we're evaluating through these secondary drivers now too, because like I said in my presentation portion, a lot of this work has been going on in silos for so long, but bringing it to a collective impact state, it's important to go back and make sure we're actually making the impact we desire. So program evaluation, I think, is key.
Yeah, and this is Colette. Some of the program evaluation efforts, specifically around HIV, come from external third parties that measure that. The Department of Public Health, CDC, you know, getting our reports annually on viral loads across the community. So, you know, many of the secondary drivers in ours are direct impact from these public health measures. Other secondary drivers are really going to be specific program implementation, like did we increase the number of healthcare settings that are going to be doing HIV testing? That's an interim lag measure that says if we have more testing sites, we're probably going to pick up more cases earlier. So yes, I would say that we're probably most uncomfortable with how to assess the knowledge and education shift and transfer and the impact on stigma. And so that's where we probably would have the most to learn from an evaluation model.
Great, thank you both. We have one more question here, and Ron, I might kick this question to you. It asks, what are the key differences between a driver diagram and a logic model?
Thank you, Kathleen. The way we often think about the driver diagram, the population health driver diagram, is as an actionable logic model. And a lot of people in public health love and use logic models. And a lot of people in healthcare, especially hospitals and health systems, use driver diagrams for their clinical types of activities. And having the population health driver diagram is a nice way to sort of bridge what the public health and the healthcare communities do. So I'm glad that you saw the logic model in the driver diagram, and really the difference is we think of it as more actionable and leading you to those particular drivers to move forward. So with that, what I'd like to do is, we have a couple of remaining slides here, but the first thing I want to do is to thank Jack and Brett and Coletta, Monique and Shauna for wonderful presentations and discussion, and for all of the efforts that you've made to improve the health of your communities. I think we've heard some great progress from the two hospitals and their communities thus far. And it sounds like you're going to be continuing the work, which is wonderful. Some additional resources that you may be interested in are additional information about this initiative and some of the previous webinars that we've done about this initiative. You can also click and go to the community guide here. There are resources from Catholic Health Association and the Association for Community Health Improvement to help with community benefit activities. And then we also have more information on our website about the driver diagram and how you could use the driver diagram. In addition, the Public Health Foundation, we do work in the field, and we're always happy to come out and participate with you, get our hands dirty with you on these activities, and feel free to contact me about that. And then if you're interested in staying informed about these types of activities and others in quality improvement, performance management, and workforce development, please sign up for our PHF e-news. And as Kathleen mentioned to you earlier, these slides on the webinar itself are not hyperlinked, but the slides that you can download do have the hyperlinks in them. We also have a couple of other upcoming webinars. One is about an academic health department partnership and how it's helping a rural community. This is the academic health departments are where health departments and academia are working together to really help to enhance the capacity of the public health enterprise, both on the academic side and the practice side, so that they're helping their communities improve. And also we have a webinar tackling big challenges with a full QI culture shift. And this is a presentation from the health department who really has embraced quality improvement and has developed some new approaches where this has been integrated into virtually everything they do and is being used as part of the health equity work, et cetera. So please, if you have the time and the interest, join us for those webinars. And last but not least, we have a variety of resources here. We have competencies for population health professionals. These are nearing finalization within the next month or two. We've gone through several rounds of public comment and had a lot of feedback, and we are rounding these out now. Once they are finalized, we'll also be steering people to some training that actually can help build some of the skills and competencies that are mentioned in the population health competencies. We also have a book that came out now last year on population health. We have 27 chapters from 30+ authors looking at population health from healthcare side, public health side, measurements, health equity, et cetera. Train, our learning network. We have right now over 1.75 million learners on Train. It's a free resource to use, and there's thousands of courses, many related to population health. And last but not least, we also have our core competencies for public health professionals, and those have served as the framework for the population health competencies. The core competencies for public health professionals are a consensus set of competencies embraced by 23 national organizations in public health, and really have been used to help guide education, training, and practice in public health. So what I want to do at this point again is thank our presenters and thank you as our attendees today. We very much appreciate your involvement, and we hope that you stay in touch with us, and we will continue to put out information about the progress of the 4 hospitals that have been engaged in this initiative over the past 3 years. Thank you again very much, and have a pleasant rest of your day.